In this episode, I would like to provide a simplified and high-yield algorithmic approach to an infant who presents with cyanosis. So the core index case is an infant with cyanosis. What is the very next step in the assessment? If the infant is otherwise stable hemodynamically, we focus on assessment of oxygen saturation. What are the three important conditions to bear in mind when approaching an infant with cyanosis? Peripheral or acrocyanosis that will have normal oxygen saturation, and the conditions with abnormal pulse oximetry that we would like to categorize them into three groups at the beginning, at the onset. One is the conditions with upper airway obstruction, two is the conditions with cardiac abnormality, and third is the respiratory causes of cyanosis. Now, talking about the first rule out, which is peripheral cyanosis, that's an infant with normal SaO2, and usually they will have acrocyanosis. What are the considerations? We need to know that acrocyanosis is usually considered normal, and if you are asked what are the clues in favor of acrocyanosis, it's the cyanosis that is limited to distal extremities. Possible perioral region can be also involved, but the infant is otherwise healthy and SaO2 is within the normal range. What are the differential diagnoses of acrocyanosis? One is the vasomotor response, for example, to cold exposure. The second important differential is polycythemia. What's the management of peripheral cyanosis? No management is required. It's considered normal, and so reassurance is the next step. If there is any worries about underlying etiology for polycythemia, we can order CBC and hemoglobin hematocrit studies. Okay, next is when an infant with cyanosis has abnormal pulse oximetry, or you may be provided some clues in favor of central cyanosis. What are the cyanosis that is present in the mucosal membranes other than just a perioral area, or cyanosis that diffusely involves the body? Another way is just to say the pulse oximetry is abnormal for the age. Here is the most important question. What is the approach to central cyanosis or an infant or kid with cyanosis and abnormal pulse oximetry? Always categorize these infants into first rule out condition, two differentiation between cardiac versus pulmonary causes, and three other additional tests. So again, when we have central cyanosis, what are the rule out categories? The rule out categories could be a normal variant. Yes, central cyanosis could also have normal variant, or a not to miss, in other words, life-threatening condition. What is the normal variant? Always remember, it is possible and normal for a newborn infant to have central cyanosis with low SpO2 within the first 10 minutes of life. Just repeat the oxygen saturation in 10 minutes. That's the only thing needed to be seen. However, if it persists beyond 10 minutes, we need to follow the rest of the algorithm. Okay, what is the first step then if the central cyanosis is present after first 10 minutes of life? The first condition to rule out is the upper airway obstruction, regardless of age. Now we will discuss the differential diagnosis of conditions associated with upper airway obstruction in a separate episode. Just remember, these are the differential diagnosis of stridor also. For now, remember, there are just two categories. One are the acquired categories, such as laryngeal spasm, mechanical causes of obstruction such as foreign body or trauma causing, for example, hematoma, or some infectious causes such as croup, epiglottitis, abscesses, bronchiolitis. Then we have congenital causes such as the malasias, laryngomalacia, tracheomalacia, vascular ring, and congenital causes of subglottic stenosis. For now, remember that the best way to formulate the approach to upper airway obstruction is to think if we are dealing with an acute or a chronic process, if we are dealing with an infectious or non-infectious etiology, and then also in more depth detail analysis, try to figure out if you can understand the phase of a stridor. Is it inspiratory, is it expiratory, or is it biphasic? More on that on the episode on upper airway obstruction. Now, if you have ruled out acrocyanosis, normal central cyanosis of the first 10 minutes of life, and the life-threatening conditions associated with upper airway obstruction, now we can finally turn our attention to the juice and meat of this approach, and that is how we really approach the central cyanosis, especially focusing on differentiating cardiac versus pulmonary causes. How do we differentiate respiratory versus cardiac, or pulmonary versus cardiac causes of central cyanosis? Always remember, in addition to the clinical presentation, we need to perform a couple tests. One of them is the screening test after pulse oximetry, and that is assessment of pre and post ductal saturation of oxygen. And then we need also to evaluate the response to 100% oxygen supplementation. Now, how do we evaluate pre and post ductal SpO2? We evaluate SaO2 or SpO2 in the right arm versus any of the lower extremities, left or right, because right arm is always going to be preductal and lower extremity is always going to be postductal. What are the positive results of this pre-postductal SpO2 assessment? If SpO2 is less than 90% in any extremity, if we get SpO2 less than 95% in both upper extremities, or if we get more than 3% difference between upper versus lower extremity, that is the post versus preductal difference. Describe 3 methods through which we can differentiate cardiac versus pulmonary cause of central cyanosis. One is presence of any positive finding in the congenital heart disease assessment or screening by pre-postductal SpO2 comparison. That is, any of the 3 positive findings we said would hint in favor of cardiac cause of cyanosis. 2 is if SaO2 or other ABG values are non-responsive to 100% oxygen supplementation. That also supports presence of a form of cardiac shunt. The pulmonary respiratory causes would be responsive to O2 supplementation with 100% FiO2. And of course, the third evidence will be clinical findings. For example, clinical findings in favor of a cardiac abnormality such as a murmur, symptoms of heart failure, etc. Now, if the screening with pre versus post-ductal SpO2 is positive, what is the next step? Well, positive screening with pre with post-ductal comparison indicates heart disease as underlying etiology of cyanosis, and therefore the next step will be confirmatory evaluation by echo. I've mentioned here that the cyanotic congenital heart diseases are usually associated with early cyanosis, while the tetralogy fallow could be associated with late cyanosis, and the acyanotic conditions before the Eisenmenger will not be cyanotic, but in the Eisenmenger phase could be cyanotic as well. Finally, what are the possible pulmonary causes of central cyanosis? Well, if the patient has symptoms of pulmonary disease such as shortness of breath, cough, snoring, hemoptysis, abnormal breath sounds, either wheezing or a stridor, we are dealing with pulmonary diseases. These patients are responsive to O2 supplementation, and therefore we need to do the workup of pulmonary disease. It could be infectious, could be COPD and asthma, it could be some of those congenital conditions such as arteriovenous malformations, vascular rings, cystic fibrosis, trauma, other differentials of pulmonary disease that could be associated with cyanosis. So once more, to put everything in perspective, the first test is SpO2 if SpO2 is normal, or if we have symptoms compatible with peripheral cyanosis. Reassurance is the only thing needed. But if SpO2 is abnormal, we first need to rule out the normal variant, which is first 10 minutes of life, or the life-threatening conditions in association with upper airway obstruction. Then we are dealing with the cardiac versus pulmonary causes of central cyanosis, and those are being determined by response to 100% FiO2, as well as the screening test for congenital heart diseases, and that is comparing preductal with postductal SpO2. If the previous steps in the workup, as I classified, is not yielding to a diagnosis, we have secondary workup that would focus on metabolic conditions and neurologic disorders, as well as the causes of apnea, such as breath holding spell or apnea of prematurity. What are the possible metabolic conditions to consider? Methemoglobinemia and hypoglycemia. Among the neurologic disorders, the ones that could be associated with the apnea and cyanosis are seizure, neuromuscular diseases, and Guillain-Barré syndrome. And finally, for differentiating between apnea of prematurity and breath holding spells and silent seizure, please listen to that episode. And this summarizes our approach to infant or kid with cyanosis. Thank you.